everyone, Leslie Cornwell here, Midwifery Business Consultation. This online presentation is resolving shoulder dystocia. I want everyone to understand different methods to help take care of this medical emergency. The definition of medical emergency is something where minutes matter, and it's not so much for mom, but for baby. We want to make sure that there's good oxygen to the brain and that we're resolving the shoulder dystocia and getting the baby to rotate in the pelvis appropriately. So learning objectives: confidently define what a shoulder dystocia actually is, understand how cardinal movements of labor play an important role in how a shoulder dystocia occurs, understanding how maternal pelvic types can affect a shoulder dystocia. Pelvimetry is a lost art with midwives, but it does give you some benefits in the back of your mind to know what positions to offer, what ways to help prevent a shoulder dystocia. Be able to name the 5 types of shoulder dystocias, be familiar with the maneuvers available to help with shoulder dystocias, be able to explain contraindications to certain maneuvers. So let's review the anatomy. Let's look at the 4 pelvic types. So a traditional quote-unquote normal female would be more of that gynecoid pelvis. 50% of the population has it. It's a round shape, adequate pelvis, good prognosis. So about half of our women have that. An android pelvis is more that heart-shaped male, quote unquote. It tends to have a narrowed symphysis pubic arch. Its capacity is reduced in all dimensions. It's a harder delivery pelvis. If they quote unquote say you have good birthing hips or not good birthing hips, a lot of people are referencing this internal shape of how the baby will come out. So with a male android pelvis, it tends to have a little harder poor prognosis just because there's a tighter space for the baby to fit through. So higher chance of a C-section and shoulder dystocia. Anthropoid is like a ape-like shape. It's the oval shape, adequate pelvis, pretty good prognosis. 25% of women have that shaped pelvis. So a lot of times when you're doing a vaginal exam, that we say it's really roomy in the back. There's just a lot of space for that baby to rotate. A platypoid is a flatter female pelvis. You have kind of a narrowed space between the symphysis pubis and that posterior, the coccyx. There's just not much room, but there's lots side to side. So 5% of women have this, so it's not as common to see. It's a round shape, reduced capacity. It's a poor prognosis. It's harder for the baby to rotate, especially in today's hospital delivery setting where women are in a lithotomy laying on their back. You're already narrowed with this pelvic position, and then laying on your back narrows it more with gravity. Cardinal movements of labor are really important to understand because they're that rotation the baby does. The baby doesn't just come out, they rotate like a corkscrew. That's why doing different labor positions, constantly changing the angle of the hips really is important during all stages of labor, especially when the baby is rotating its head towards the end during pushing. So it has to do with engagement, descent, flexion, internal rotation, extension, external rotation. So that's that normal restitution where the baby's head is out and we're waiting for the next contraction for the shoulders to rotate, and then expulsion. So these are cardinal movements of labor, typically towards the end at delivery time. And if we respect the birth process, you can actively see that happening. Normal delivery of the shoulders. So this is what you would expect to see if you could look inside the mama during those cardinal movement rotations. The anterior shoulder will appear first, the posterior shoulder will swing up to be born, and then the shoulders will often fold to reduce the width because after the head comes out, the shoulders are the widest part of the baby. So these are just basic anatomy. Your joints, your ligaments, and your hips, especially during labor, become really loose and elastic, and they can move easily. So that's why doing different positions, side lying, hands and knees, squatting, lithotomy. There's so many positions to do to help. I love the stairs. That really is a great option. And so when we think of a shoulder dystocia, it's one, making sure the baby is safe, but there can be a lot of damage with the brachial plexus injury. The clavicle can get broken. The shoulder can be pulled on too hard by the care provider when they're trying to deliver the baby and cause long-term nerve damage for the baby to use its arm. And that's where a lot of the lawsuits with shoulder dystocias come from, is the brain damage and the brachial plexus damage. Clavicles heal, they're a bone. It's more just a temporary concern. The purpose of the maneuvers is to either increase the size of the pelvis. That's why McRoberts maneuver is really helpful. Decreasing the bisacral diameter of the fetus, so the suprapubic pressure. A lot of times the nurse in the hospital setting will be asked to push because your goal is you're trying to shrink the space for the baby to get the shoulders through. Changing the relationship of the bisacral diameter with the bony pelvis by rotating the baby. So that's why different positions are, the Gaskin maneuver is really helpful. You're trying to get the baby to rotate to the bigger part of the pelvis versus you're forcing the baby out. So the goal that I want to focus, because it has better outcomes, you're not pulling on the baby. Try to get the baby to rotate in the pelvis versus we're using our hands to really get aggressive and pull on the baby. So we want to rotate. See how much more room you have if the shoulders are in more of an oblique versus up and down dimension. Shoulder dystocia is the arrest of the shoulders during delivery. The head is out, but now the shoulders are stuck. There's different ways the shoulders can get stuck, so we'll talk about that a little bit more along. The shoulders fail to emerge spontaneously after the head is born, and that's more of a medical definition. With midwifery, water birth, normal birth, it's the shoulders will deliver after the next contraction, as long as there's no signs the baby's face isn't getting good blood flow, turning purple, there's a tight tension on the neck. So midwives a lot of time will feel, is there like a nice gentle gap between the head and the shoulders, or is the baby really feeling pulled on and the face is turning purple? Then you need to act versus waiting for the next contraction. So impaction of one or rarely both shoulders during a descent into or through the pelvic brim, or when the shoulder girdle does not fit through the bony pelvic outlet. It may also involve a malrotation, a disproportion between the soft and bony tissues of the baby's shoulders and the mom's pelvis. So there's somewhere that the shoulders are getting stuck because of the angle, the mom's shape of her pelvis. The baby didn't get a chance to do cardinal movements, so there's risk factors with like a faster delivery for a shoulder dystocia. Bigger babies, there's just not a ton of hard evidence to say they're more likely to get a shoulder. It's more of just stuck. Shoulder dystocia is not defined by time. Older medical literature used to stress the importance of time. I know in a hospital setting, we have to be very careful of noting the time of delivery of the head and time of delivery of the shoulder. More for litigation purposes, not so much for outcomes, and is that the way we define it? You can talk to many different care providers and they will define shoulder dystocia differently. Sometimes it's really easy, like, okay, I had to do 3 maneuvers, that shoulder was really stuck, but there's times where it was just normal restitution, and I hear a care provider say, oh, that was a shoulder dystocia. So you just have to be really careful of, to me, if I do one simple maneuver to rotate the mom from side lying to hands and knees and the baby comes out, I don't consider that a shoulder dystocia. I consider it, I had to do active maneuvers a few times. I had to physically work with the mom as a team to get the baby delivered. Contemporary lack of understanding really affects this process. The normal, quote unquote, head to body delivery interval for midwives, it's a lot longer than it is for the medical community, especially if you're waiting for normal restitution, which is rare to be seen in the hospital setting. Shoulder dystocia rates do increase when you start making it about time versus intervention and the shoulders actively being stuck. Normal birth of the shoulders. Important to be familiar with normal processes of the shoulders birth in order to understand how shoulder dystocias develop. Sometimes the head and body are born in one swift motion, especially if she's had a baby before. It tends to be more normal restitution with first-time mamas. But it's once that baby gets low in the pelvis, her body is actively trying to deliver that baby. If not, the head is born and there's usually a pause, and it's typically a few minutes because it's waiting for the next contraction to help rotate the baby. The baby's neck is not being compressed and the circulation to the head is unimpaired. So the head's not turning a bright purple. It's got a nice soft gap. Like if you take your hand and you go against the baby's neck and the mom's vagina, you can easily have a nice gap there. You're not feeling tension on the shoulders. You're not feeling the neck is getting stretched out from the shoulder being caught. The next contraction facilitates shoulder rotation in the birth of the baby. In the upright and mobile mothers, this posterior shoulder descends into the roomy part of the posterior pelvis and is born first, and then the anterior shoulder is quickly followed. In the medical community where there's active management of the birth process, the anterior shoulder tends to be delivered first. Incidence, there's sources vary widely. They can range from 0.15% all the way to 0.3%. Larger babies are at greater risk. There's still studies saying you're just as likely to have a little baby as a big baby for a shoulder. But that's the first thought in the medical community is, oh, big baby, got to watch for shoulder dystocia. But understand, you can have a baby with no risk factors, still have a shoulder dystocia. Vast majority of large babies are born with no difficulties. The comment we always say, if you're expecting a shoulder dystocia, it probably won't happen. A shoulder dystocia typically happens when you the least expect it. Interfering with the normal birth process increases the risk. Inductions of labor, assisted deliveries with a forceps of vacuum, anything where you're impairing the cardinal movements of labor. I truly believe epidurals have an increased risk of shoulder dystocia. I haven't found any evidence to directly support that. But when you're narrowing the pelvis, you're limiting the mom's mobility and her to help with the process of rotating the baby, it does increase the chance of the shoulders getting stuck. Fetal risk factors, bigger baby, symmetrical and constitutional macrosomia. That has to do with a baby being just big all the way around versus a diabetic mother's baby that's bigger tends to have a bigger chest, a bigger shoulders to work with versus just overall a bigger baby. So there is a difference between, okay, is this a big baby because it's a diabetic baby or is it a big baby because of genetics? Because they found direct links of the shoulders being proportionately larger than the rest of the body, increasing the chances of a shoulder dystocia. Shoulder dystocia by weight. So yes, there is a pretty significant increase. 10% of the babies that are greater than 4,500 grams, about 9.5 pounds, have a higher chance. They've just got bigger shoulders going through a mom's birth canal, especially if she hasn't had a baby before. Each pelvis has a max capacity of what size baby could fit through it, no matter how many hormones are going through her system to help get the ligaments stretchy and elastic. Fetal risk factors, a baby that's post-dates overdue tends to be a little bit larger, so that's part of those risk factors for shoulder. They've also found that there's more calcification of the bones, so they're not as pliable and able to bend as well. The older the baby is, the firmer the bone structure is, especially in the shoulder and the clavicles, to be able to maneuver through the pelvis. There's no evidence of a boy baby versus a girl baby has a higher chance of a shoulder dystocia. Maternal risk factors. It has to do with her pelvic shape. It has to do with her induction of labor, laying on her back, helping out the cardinal movement of labor. So we're going to specifically talk about her shape of the pelvis. Inlet dystocia, a low pubic arch, and a narrow diagonal conjugate. Women with platypoid pelvises are 8 to 10 times more likely. So that's that real oval shaped where it's not much room between the pelvic brim and the coccyx. So it makes it hard for the baby's shoulders to rotate at the very end. An outlet dystocia, presence of a narrow pubic arch and a reduced conjugate of the outlet. Other particularities, prominent sacrum, prominary, and then a flat sacrum. So it really has to do with narrowing. When you don't have that oblique diagonal that the shoulders can rotate into, it makes it a lot harder for delivery. Maternal risk factors, if she's had a shoulder dystocia before, she's at a higher chance because we don't know if it's because of her pelvic shape. It makes a difference to me if it's a first-time mom that had a shoulder dystocia and now she's having her second baby versus she's had 2 other kids, now she had a shoulder dystocia and she's having another baby. I do look at it differently. So an example, my worst shoulder dystocia I ever had, she had 2 girl deliveries, totally normal, healthy, and then she had a boy that was about a pound and a half bigger than all her other girls. Her girls were low 7-pound deliveries, term, healthy, and then her boy, her third pregnancy, was about 8.5, 9 pounds. So that was kind of the max for her pelvis. It was a really tight shoulder dystocia. And so when she got pregnant with her fourth, we had a lot of discussions. She was going to find out on if she was having a boy or a girl. We talked a lot about genetics and the size and the maneuvers and what we could do. She decided to have another home birth. She had a little girl that was the same size as her other babies and had no issues with a shoulder dystocia the next time. So it's not just about did she have a shoulder dystocia in the past. It's looking at how far along was she? How big did the other babies weigh? Did she deliver on her back? Was she an induction? Was she able to actively, like I look at it differently if it was a shoulder dystocia at home than it was a shoulder dystocia in the hospital, because it makes me a little more concerned she was able to actively move. She wasn't being induced. She didn't have an assisted delivery, especially if it was a smaller baby. So there's a lot to think about. Use of regional anesthesia, so that has to do with the epidural not being able to move the pelvis and help with the descent of the baby as much. Slow progress during pushing. You always wonder if the shoulders are getting stuck or if it's the birth of the head, especially with a multip. If she pushed really fast and had a short delivery time with her last one, and now she's pushing, you always wonder, okay, is the baby asynclitic? Is there a shoulder getting stuck? Is this baby a lot bigger than her last one? There's a lot to think about. The delivery position. Women that are delivering on her back, where the pelvis is naturally being narrowed by gravity, has a lot less space to work with versus a mom in hands and knees and squatting in the water or birth stool. There's an extra centimeter and a half of room we're being given when a mom is using those positions for delivery. The mom's fear. If she's had a history of abuse as a child, especially sexual abuse, and there's a lot of tension in those nerves from all the feelings she's having, the muscles tense up. You can actually have a shoulder dystocia, not from the bones, but from the mom having so much fear, having so much pain, having so much tension in those pelvic muscles that she can actually cause a shoulder dystocia. I've had a couple that way with first-time moms, super young, so much going on, and her body was just literally squeezing that baby in. So we have to focus not so much on medical interventions, but relaxing and calming and supporting the mother so she can relax her bottom to help the baby come out. Other risk factors, a fast descent of this baby. If she has didn't push barely at all, you have a higher chance because the baby didn't rotate in the pelvis very well. Cord entanglement, a short cord. If the placenta is a fundal placenta and there's not much of a cord, it's like a bungee. The baby tries to deliver and it's not as much the shoulder holding the baby up as it is the umbilical cord. So you just always have to make note, okay, I don't feel the shoulders are caught. Why is the baby not coming out? Because if you pull too hard, you don't want to cause a placenta abruption. You don't want to rip the cord. You have to think about the different possibilities of why is this baby not delivering. Drugs that affect the uterus can impair normal rotation. So terbutaline is a medication in the hospital given to relax the relax the uterus if there's a lot of contractions at once. Sometimes even Pitocin is given and the receptor sites get tired from the Pitocin, so they don't work as well. A late rotation of a large posterior baby can cause shoulder dystocia, especially if she's encouraged to push when there's just a little bit of cervix left, when there's no urge. We want to wait till moms have that urge. The baby is low enough in the pelvis. It's not based on, oh, she's 10 centimeters, she has an epidural, now it's time to push. Remember, many cases of shoulder dystocias can occur with no risk factors. And I would tell you honestly, the times I thought about a shoulder dystocia, it didn't happen. The times you say, oh, this is going to be one, it was the women that I least expected that I now had to use those emergency skills. 2 in the morning, sleep deprived. You have to know these things in and out, how to help women. Can a shoulder dystocia be prevented? I would say most of the time it can. We can reduce the risk, but it's never going to be 100%. By delivering a woman in positions that optimize the size of the pelvis, so hands and knees and squatting is going to reduce the risk versus delivering on her back. Having a naturally laboring woman with no epidural or pain medication that's limiting her positions will also decrease the chances of a shoulder dystocia. Having a care provider that respects and understands the normal restitution of labor versus actively trying to deliver the shoulders will affect a shoulder dystocia risk. So there's a lot of things to think about, and understanding the shape of her pelvis, being proactive, what positions are best for this woman to try. Proposed methods to prevent a shoulder dystocia. A lot of it is just prenatal education, having a discussion with the mom of different maneuvers, different things, working as a team. If she's actively delivering her baby, it's very overwhelming to have a baby coming out and then all of a sudden realizing, oh my goodness, my care provider, my midwife needs me to do XYZ. There may be moments when you're so overwhelmed with your sensations to need to be a team with the midwife and reposition, help, push at certain times. Assisting in rotation of that occiput from posterior. So we want to help with preventing that incomplete rotation during descent. So it's not rushing the pushing, letting the mother listen to her body of different ways to angle her hips. Avoid pushing on a soft indentable surface. So that has to do with hospital beds. I love my birth stools. I love water births. I love women just slow dancing with their husbands in taking advantage of gravity and rocking your hips back and forth. Proposed methods for preventing shoulder dystocia. Avoid birthing in a tight space when there's not as much room to move around. It makes it harder for the care provider to reposition the mom, especially if you have a tub and it's a small apartment. You have to be really considerate of the space around you, how much equipment is there, how much furniture. Wait for the urge to push. It's harder with an epidural, but in natural labor, just because the cervix is gone doesn't necessarily, it's that Ferguson reflex, it's that baby being low enough in the pelvis to involuntarily cause mom to push. Be sure the mom's bladder is empty. It's really important, especially with an epidural. She's not going to know, but a full bladder is like a balloon and it can cause a shoulder dystocia. So we have to worry about her muscle tissue. We have to worry about her bones. And now we have to worry about this bladder. It could be full. So when she's having a baby and there's no epidural, she tends to be going to the bathroom. She's going to the bathroom while she's pushing. It might be just a simple idea to recommend sitting on the toilet and doing some pushing that way and emptying your bladder at the same time. Proposed methods for preventing shoulder dystocia. Postponing pushing when the mom's exhausted. It is hard. If her body's involuntarily pushing, just let her body push. Encourage her to rest in between. Forcing the mother and uterus to get the baby out, it makes it a higher chance. Weak mothers tend to have ineffective pushing. Her uterus is tired, her body is tired. You're going to have a higher chance of a shoulder because the body can't help rotate to get the baby out. Apply suprapubic pressure tends to be more in the hospital setting, but it's a way to, the head is out, the shoulders are a little tight space. You can help manually shrink the shape and the size of the shoulders to deliver the baby. Maintain the pressure until the head. So you have to work as a team. Your birth assistant would apply the pressure over the mom's symphysis pubis, and then the midwife care provider would rotate the baby. Encourages the shoulders to rotate under the pubic bone rather than behind it. Birth of the head with a contraction. It's really important. If you're trying to tell the mom to push, but she doesn't actively have a contraction, she needs her uterus, she needs her body to help her We don't want to interrupt that natural process. That's why normal restitution is so important. I think a lot of care providers cause shoulder dystocias because the head comes out and now the contraction is gone and they're trying to get the mom to push the baby out when the contraction isn't there to help with the rest of the rotation. Mechanisms of labor. Remember the last part of cardinal movements. Extension, internal rotation needs to be complete. The fetal head passes behind the symphysis pubis while in flexion. External rotation, that's that normal restitution. The head is out, we're waiting for the next contraction, the shoulders will rotate as long as there's no signs of stress. As long as the baby's face isn't purple, there's not that tightness on the neck. Expulsion, that's where first the anterior, then the posterior shoulder passes through the symphysis pubis. Wait for the contraction following the birth of the head before attempting to birth the shoulders. So now you've had your contraction and now there's no rotation happening. That's when you start saying, let's look at options to help. Shoulders do not instantly follow the head in many normal births. A lot of times it's with women having a lot of babies that it all is one fluid motion. Many women, it's that normal restitution. We need to respect that process. Is manipulation needed sooner than the next contraction? So those are those things I was talking about, signs that the baby is showing stress, that there's a pretty significant shoulder dystocia present. It's not normal restitution. That's that slight retraction. You'll see a turtling, that the baby's face is squished against the perineum and the cheeks are really, the skin is just, it's real like a puffy, like the kiddo is got its neck stuck in a turtle sweater. It's a lavender pink head against a perineum after the contraction. That normal, a little bit is fine. And that's why I use my hands, especially in a water birth. You want a light, you want a mirror, you want to use your hands to know if the baby is not getting impaired blood flow. True impaction is that significant darkening. It's not just a little bit pink or purple, it's pretty dark purple. And signs of concerns that are present, you don't want to wait for the next contraction, but most of the time in normal restitution, let the body do its thing. Trust in the cardinal movements of labor. Force of the next contraction should rotate the shoulders into the proper position for birth. Premature manipulation, so that's the care provider doing active management when the head is out and now trying to force the shoulders to do a different rotation than their plan, can cause the shoulder dystocia. Encourage the woman to relax her bottom, those pelvic muscles, be in a good position. Hands, knees, squatting are great positions for preventing shoulder dystocia and helping with shoulder dystocia. If signs of concern are present, try encouraging a contraction by firmly massaging the uterus. The mom can do nipple stimulation as well. And then you can get the baby to deliver with the next contraction. Positions for delivering, using hands and knees preventatively. I love it. Instinctually, moms have a lot of back pain. So hands and knees is a really great way to open up the pelvis. Avoid positions that limit sacral mobility. So that has to do with the traditional hospital deliveries, epidurals, laying on your back, semi-sitting. The anterior shoulder is more likely to get stuck when the sacrum cannot move backwards. Descent to the posterior shoulder is more likely to be impeded. So you're just narrowing that pelvic arch. Horizontal and lateral positions are best. So I love side lying for women that are going really fast. You're not having gravity accelerate the labor process. So for mamas that have a history of fast labors, lateral side lying positions are really great as long as she's comfortable being in that way, because you're not having gravity accelerate the birth of the baby. So this is a great picture of hands and knees, and when the baby comes out, what we're seeing with the shoulder. Parker position is an upright kneeling position where you're slightly leaning forward. It's a great way to accentuate that oblique diameter of the pelvis. A surefire way to avoid problems with the birth of shoulders. Allows maximum pelvic flexibility and encourages the posterior shoulder to birth first, creating more room for the anterior shoulder. So it's a great position for mamas to deliver their babies. And then there's a great video on spinning babies, resolving shoulder dystocias. You're more than welcome to watch from Gail Tully. Where are the shoulders? So sacral prominent, and it's helpful for you to know because each maneuver is going to be different. Where's the shoulder stuck? Is it stuck high in the pelvis? Is it stuck on that outlet brim? Is it stuck in the mid pelvis? Where are the shoulders stuck? Because that'll help you determine which maneuver to. Types of shoulder dystocias. An inlet shoulder dystocia is where it's unilateral in its low anterior, or it's bilateral, meaning both, and it's high up in the pelvis. An outlet shoulder dystocia is that unilateral incomplete rotation of the chest, unilateral outlet dystocia, and anterior posterior shoulder diameter becoming impacted behind the narrowed pubic arch. So is the baby's shoulder getting stuck high up in the pelvis? Is the baby's shoulder getting stuck low in the pelvis? Are both shoulders getting stuck? Is one shoulder getting stuck? Those are things you need to think about. And you use your hands for that. So if you get a shoulder dystocia, you need to use your hand and feel which shoulder is stuck, where, and what is it stuck on. So inlet shoulder dystocias, descent of that shoulder girdle becomes impacted above the pelvic brim when it's trying to engage. Those ones are harder to take care of because they're high up in the pelvis, and a lot of times the head really gets stretched out and there's more stress during the pushing process. It can result from malrotation or a late incomplete rotation of the posterior baby. It's often associated with that flatter platypoid pelvis because of that narrowed symphysis pubic arch. The shoulders attempt to enter the pelvis through the anterior posterior diameter of the pelvic inlet rather than the larger oblique diameter. So you're getting a difference of 10.5 centimeters to 12.75. So you're getting almost 2 centimeters difference in diameter. When you're birthing a baby, that's a lot of space that you're losing. So unilateral means that one of the shoulders is stuck and it's stuck high in the pelvis. This is the most common. And so what you have to do is rotate the shoulder that's stuck. You have the advantage that the posterior shoulder is in the roomy part of the back part of the pelvis. If you needed to, you could go in and grab that. So it makes your maneuvers a little bit more choices. The one that's always not so much scarier, but the hardest to handle, and my worst shoulder I ever had, was the bilateral inlet shoulder dystocia, where both are stuck high in the pelvis. So the unilateral inlet shoulder dystocia, it can be lodged on either side of the symphysis pubis and the shoulder is still oblique. May be impacted upon the symphysis. It may be the shoulder axis is anterior-posterior orientation. The posterior shoulder is below the sacral, prominent in that hollow area of the sacrum. So it's relatively easier to reach. You can see in the picture, if you needed to as a midwife, you can go and grab that posterior shoulder and deliver the baby that. So this is the one that's the hardest to take care of. This is the one that's the most severe shoulder dystocia because you have both, you can't grab either shoulder. It's just tight, tight, tight. Occurs when the anterior shoulder is behind the pubic bone and the posterior shoulder is lodged against the sacral promontory. So that means you can't reach to grab either shoulder. It's harder to rotate when the baby's shoulders are high up in the pelvis still. This one is rare, but it's the hardest to take care of. I had it once and it was by far my hardest shoulder dystocia. A large baby passing through, and that was that example of the woman I gave where she had 2 girls and then this boy was just way bigger than what her body was used to delivering in the past. It's common with epidurals. It's common with instrumental deliveries where you're trying to lose that rotation, that cardinal movements of labor, just to deliver the baby. Outlet shoulder dystocia, that more has to do with the outer brim of the pelvis. Those are when the shoulders are easier to grab and help rotate. Most likely to occur when a woman has a funnel-shaped pelvis, the android pelvis, accompanied by a shallow sacrum curve. So it's just that narrowed pelvic, the very end of the pelvis is just more narrowed. Pubic arch is likely to be higher and more acutely angled than usual. And that just makes it so that there's that steepness of the angle, brings the pubic rami and the ischial tuberosities closer together. Anterior shoulder girdle becomes impacted as it tries to pass through the narrowed passageway. And these ones are a little bit easier to manage, just both shoulders much better than when the shoulders get stuck in the inlet part of the pelvis. So unilateral is in one shoulder over another versus bilateral. It's an incomplete rotation of the chest. Rotation of the baby's upper spine and torso results in the first internal rotation of the shoulders. Shoulders may pass through a brim in the transverse position, and then arms could become lodged in a mid-pelvis between the prominent ischial spines. Unilateral is where there is the outlet on the other side. The anterior posterior shoulder diameter becomes impacted behind a narrow pubic arch. The shoulders may engage through transverse diameter of the brim and rotate to anterior posterior diameter, where the anterior shoulder becomes impacted against a narrow descending angle. So it's just that pelvis is just angled towards the end. The head took a while to deliver, and now the shoulders have to rotate through that narrowed pubic. So the bilateral is where both of them are stuck. It occurs when the shoulders are in the anterior posterior diameter of the pelvis, and the anterior shoulder becomes impacted behind the arch, and the posterior shoulder is against the coccyx. So this picture is more an inlet that we're looking at, but that's okay. Posterior shoulder is not at the hollow part of the pelvis. This is by far one of the hardest ones because the hands are stuck behind the baby. It's almost impossible to go in and reach for the posterior arm and bring it out when the baby is in this position. Inlet and outlet dystocias are complicated when one or both of the arms are behind the baby's back versus towards its chest. The normal descent rotation, normally it's just a rotation flex the shoulder girt, so you should be able to still do the symphysis pubic pressure and rotate the baby. You just can't be able to grab the shoulders, the arms with this type of. Removing that posterior arm tends to be a hallmark if you can't rotate the baby. For midwives, you put your hand in. You're not trying to break the clavicle. You're not trying to ream on the head. You're going in and getting that posterior shoulder out for delivery. It's the greatest risk is when both arms are behind the baby. It's extremely difficult to get the shoulder and arm when it's stuck behind and you're not grabbing at the shoulder, you're grabbing more at the elbow because you're trying to bring the baby's arm up. Resolving a shoulder dystocia, there's Gaskin maneuver, Parker position, standing up, a duck wide walking, a Sutton maneuver, flip-flop method, and the pack pull. Sutton maneuver assumes that a shoulder dystocia almost always results from a supine position during pushing. So that's more of laying on the back. Address the impaction of the inlet and opening up of the mid-pelvis and outlet. So the shoulder dystocias, when I get them, as soon as I do one position of rotating, most of the time the mild dystocia will resolve itself. We just need to help the pelvis rotate the baby. Extend the mother's legs. The stairs are great. Getting her out of the water easily will resolve the shoulder dystocia. Getting her from side laying to hands and knees if she's on a bed. You're trying to encourage the cardinal movements of labor. Sutton maneuver also is having the mother tip the pelvic rim as far as possible by arching her back. Sticking her belly out as far as possible can help. If the dystocia is not resolved, ask the mother to raise her upper thigh as high as possible into the air, so her knee to the ceiling. You're trying to really exaggerate that oblique diameter for the baby to rotate through. Check to see if the anterior shoulder is visible. If not, press head down slightly towards the mother's buttocks in junction of shoulder and neck being visible. So we're just giving some slight traction to help get that anterior shoulder delivered. Flex head anterior laterally, moving the anterior ear towards the mother's abdomen. Press the neck into the pubic arch in top of the anterior shoulder, because our goal is not to do extreme tension on the neck. It's just that gentle traction to see if we can help dislodge the shoulder if we can't rotate. Sutton maneuvers can be done in hands and knees when the mother is rocking on all fours and having mother raise one knee and then the other. The main goal is to confirm disimpaction of the anterior shoulder and facilitate delivery of the posterior shoulder first. allow for natural pivoting motion of the anterior shoulder against the pubic bone. So we're trying to get the mom's body and her hip angle to change to rotate the baby with cardinal movements. Flip-flop method, Gail Tully has done a lot of courses and memory tools to help birth attendants free the stuck shoulder with a little chance of birth injury. Non-drugged birthing women have more options to put their pelvis in compared to a woman laying on her back, the bed's broken down, and she has an epidural. Techniques that give leverage to rotating the baby's shoulders are the most important thing. So here's just a simple reference. You can take a picture, you can make your own for your birth assistants to help them understand why we're rotating the mom to get the baby to change angle in the pelvis. So the helper is great. It's more used for the traditional medical system. She has an epidural, the bed's broken down, there's limited options to rotate through. So an episiotomy can be used, but it's rare because it's not the muscle tone, it's the bone that's holding the baby in. The episiotomy tends to be so that the hands of the care provider can get in the vagina near the baby better. Really exaggerating that McRoberts maneuver and suprapubic pressure will give a little more angle and space with the pelvis. So the goal with suprapubic pressure and the provider is to rotate that shoulder and help the baby deliver in that oblique angle. The flip-flop method, more what Gail Tully was referencing, has to do with non-epiduralized women, hands and knees, rotating the angle of her pelvis, going from Gaskin, going side to side, doing that Parkinson maneuver, changing the angle of the pelvis so we can have her body rotate the baby. If we need to go in and help, we're trying to get into that oblique angle for her pelvis. And then the last would be bringing out that posterior arm when she's in hands and knees. Contraindications for maneuvers. Please do not do fundal pressure. Fundal pressure is pushing at the top of the uterus and trying to push the baby out. You're going to cause damage. You're going to, you have a chance of rupturing your uterus. You have a chance of causing brachial injury because it's the rotation. It's not, the baby's shoulder is stuck. You can't force the same angle to keep happening. Strong lateral traction, so pushing really hard and pulling on the baby's head does not improve the outcome. Episiotomy should only be used if the clinician needs more room for their hands, not so much the baby is getting stuck on the muscle, they're getting stuck on the bone. Stay calm. Anytime there's an emergency situation, the midwife, the provider, the physician, the nurse needs to stay calm so that the patient will stay calm. When there's anxiety and tension in a room, we don't think clearly, we make the mother nervous and tense, and now we have her muscle tone fighting us as well as her pelvic angle. So take a couple deep breaths, think about the situation, put your hands inside her vagina and feel which shoulder is stuck and where. That will help you determine what angle to put the mother in. Frantic, rough handling only causes more damage to the mother and the baby. It does not improve the outcomes. Take about 10 to 15 seconds, try a maneuver, and if it's not helping, then try a different angle. Change the angle of the pelvis, especially if she doesn't have an epidural and she can freely move. You will have a lot more advantage. Top reasons for successful claims against providers in shoulder dystocias. The provider doesn't document very well. There's a lot of absentee to the delivery note discussing the shoulder dystocia, the maneuvers that were done, recognizing it as a shoulder dystocia, the damage being caused from the shoulder dystocia, not implementing the proper maneuvers that are recommended for shoulder dystocia. So make sure that there's good follow-up. Did they have risk factors? Was there borderline glucose testing? Was there an unexpected large baby? Especially when there's diabetes, that increases the chances of a loss. Learning objectives, making sure in this section you can confidently define what a shoulder dystocia was, how cardinal movements of labor are so important with preventing shoulder dystocia, understanding shoulder dystocia, and the different maneuvers to try for shoulder dystocia. Understand how a maternal pelvis shape can affect a shoulder dystocia. Name the 5 different types of shoulder dystocias you can get, and what are the different maneuvers to resolve those shoulder dystocias. What are contraindications of maneuvers to not try? And the biggest thing I stress is don't pull on the baby's head. It is a shoulder that needs to be rotated, and figure out what angle of the pelvis to make the shoulder to rotate it. You're going to cause a broken clavicle, you're going to cause brachial plexus damage, you're going to cause long-term brain damage from not doing the proper maneuvers in the correct order. Here's some references about shoulder dystocia and ways to train your team. And I look forward to seeing you at more education.